Welcome to JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Shelby Baez, an assistant professor in the Department of Exercise and Sports Science at UNC Chapel Hill, and the co-host of JAT Chat with Dr. Kara Radzak. Today, I have the pleasure of being joined by Drs. Michelle Walaszek and Christopher Kuenze. Dr. Walaszek is a physical therapist, PhD candidate at the University of Virginia, and research associate at the Shirley Ryan Ability Lab. And Dr. Kuenze is an associate professor in the Department of Kinesiology at the University of Virginia. They are co-authors of Quadriceps Strength and Knee-Related Symptom State 6 months after ACL Reconstruction. Thank you so much for joining me today.
Happy to be here, Shelby.
Yeah. So starting off very broad for our listeners, what do we know about ACL reconstruction and quad strength in this population? Very broad question.
Very broad question. I'll try to keep it as tight as I can. So in ACL population, quadriceps strength is a pretty common clinical outcome that we use to kind of track assessments, especially in return to sport. So there's kind of two ways that we look at the strength metric. So we look at individual limb strength, and then we also look at it as a metric of symmetry between the ACLR limb and the uninvolved limb. We tend to use this because it can be used clinically and in research. So in the clinical space, we usually use handheld dynamometers. And then within the research space, we can also use those types of equipment, but then we can also use more precise measurements like biodex and those types of things. We know that in the ACLR population, with isometric quadriceps strength especially, it's more of the common metric that we use. Individuals tend to demonstrate better outcomes if they have increased strength of their ACLR limb after surgery, and then also if they have higher limb symmetry, so closer to that 100%. 100% would be that both their limbs are symmetrically strong. They have these better outcomes. So specifically, individuals after ACL reconstruction usually report better function being anything from accessing their environment on the day-to-day to performance and return to sport as early as 6 months post-ACL reconstruction, all the way up to 13 years after ACL reconstruction. So those are kind of things that we look at. And then it's also been associated with, specifically symmetry has been associated with a decreased risk of re-injury in this population. So we kind of want to make sure that those quads are functioning appropriately and they're functioning very similarly after ACL reconstruction. Anything to add, Chris?
That the timing also matters. So recently there's been a series of studies that have come out that have looked at not just is strength related to re-injury or to long-term outcome, but when you measure strength, does that matter? And it does seem like earlier after surgery, maybe 3 or 4 months after surgery, folks who are more symmetrical and stronger may actually have a higher risk of re-injury within 2 years because they gain confidence more quickly, they get cleared to participate in sports more quickly, they're exposed to things that are high risk more quickly. And then at later time points, 7, 8, 9 months after surgery, folks who have higher strength or better symmetry seem to be potentially at lower risk for re-injury. So there is something about when we do the assessment, when in the clinical progression it occurs, that lets us know kind of whether or not it's a good thing or maybe a not so good thing.
Yeah, that makes a lot of sense. Michelle, you were mentioning a little bit more about these different clinical criteria and clinical cutoffs and limb symmetry. Just for some of our listeners who may not be as familiar with LSI and clinical threshold cutoffs, can you just talk us through these different clinical cutoffs and what are they associated with, specifically as we think about outcomes after ACL reconstruction?
Yeah, for sure. So in the individual limb, there's been a established criterion for several years now. We use this metric, anything greater than 3.0 Newton meters per kg. An easier way to kind of think about this is 3 times your body weight. Anything above that is considered to be kind of this better outcome. And I'll let Chris kind of speak more to this since he was the author on that paper. I'll talk about kind of this limb symmetry index. So in the clinical space and the research space, we often use this 90% limb symmetry index cutoff. It's essentially just a metric looking at the ACLR limb function over the uninvolved limb function, multiplying it by 100 and getting a percentage. So we typically use this 90% cutoff in the clinical space for return to sport. It just kind of helps us track objectively how that ACLR limb is doing in relation to the uninvolved limb. And so anything less than 90% is considered to be like a higher risk for re-injury in this population. Again, to Chris's point, kind of that timing of when this is all happening is important as well. And I think, as he said, there's been newer research studies coming out about when that timing is the important thing to reach that 90% or greater. The one thing we kind of don't know at this point is above 100%. So if that ACLR limb is doing better strength-wise, or maybe for hopping metrics, is that a good thing or a bad thing? So I think one thing we need to think about in the future for this population is looking at healthy individuals that are uninjured and seeing kind of how this symmetry metric plays out. And so that's kind of where we stand right now. I know Elizabeth Wellstan had a paper on kind of this symmetry index and its kind of relationship in the ACLR population, and that might not be the best metric to use to track return to sport objectively. So Chris, you want to talk a little bit more about the 3 Newton meters per kg in the individual limbs?
Sure. Yeah. So I published a paper maybe, I don't know, it's almost 10 years ago now. I think I'm getting old. And then Brian Petra-Simone down at the University of North Carolina also around the same time published a very similar paper, and we found something that was like extremely similar, which is always a good thing. You know, replication is really important. The 3.0 metric really came from looking at the association of quad strength in the ACLR limb to like knee-related function or knee symptoms. So it wasn't an idea that was related directly to risk of re-injury or to development of OA or even likelihood of return to sport at a later time. And so I always like to put a big asterisk in front of the 3.0 metric because it means something, and it's been replicated now several other times since Brian and I initially published our papers around the same time. But I think trying to use that as like the end-all be-all metric is a bit challenging. It also doesn't take into account growth and development, maturation. You know, is it normal for a 16-year-old to be able to lift 3 times their body weight? It may not be. Or for a 55-year-old who's a weekend warrior. You know, these are things that we just don't really know. We have 2 projects going on right now where we're hoping to set some age-specific criteria for folks, but I completely agree with Michelle's point that you know, having a better understanding of what a healthy person at a certain point in their life with a certain activity level, that really probably is our better static measure to use, or maybe some combination between a cutoff score and a healthy measure to give us an idea of like what's a normal range of values. Because Shelby, I can guess, you know, you're not a cutoff score lover, and part of the issue is that there's variability in every measure, right? There's always kind of this moving target or a range of targets that are acceptable. And so you know, the 3.0 is a great little benchmark, but it's probably not meaningful in every patient or every population or at every time point after surgery.
Yeah, so it sounds like just a lot of variability in how you can measure it, what we should be measuring, and how to make sense of quad strength after ACL reconstruction. But what was interesting in this paper is that you all included the symptom state to help to try and characterize quad strength. Can you just discuss what was the catalyst for the inclusion of this patient-reported function and symptom state to understand quad strength after ACL?
So Englund et al. In 2003, they established this criteria that we used in this paper, and I'll kind of talk about it a little bit more in a bit. But essentially what they did was they wanted to look at this patient-centered metric. So like patient-reported metric of how these individuals are doing after this traumatic kind of experience in their knee. So basically what they did was they wanted to look at this metric to inform out seeking additional medical care for knee-related symptoms. So in the paper, we discuss it as clinical knee-related symptoms, and I'll kind of refer to that from now on. But essentially, they were looking to see and understand how patients specifically are feeling. So it's more of a subjective assessment, but in conjunction with an objective questionnaire that we often use in the ACL population. So they took the knee injury and osteoarthritis outcome score, or the KOOS, and they established kind of these breakdowns of where it occurs. And so there's kind of two pieces to that algorithm that they came up with. So the first one has to do with one of the 5 subscales of the KOOS. And so it has to do with the quality of life subscale. And then you have to meet certain metrics for the other 4 subscales. So that includes symptoms, pain, activities of daily living, and then sport and recreation. I can speak a little bit more about the specifics of those if you'd like me to, Shelby. Okay, so basically individuals who scored less than 87.5 on the KOOS quality of life and met 2 of the following criteria. So KOOS symptoms less than 85.7, KOOS pain less than 86.1, KOOS ADL less than 86.8, or the KOOS sport and recreation less than 85.0. And so this is kind of a inclusive classification for these individuals, but it does kind of take into account or emphasize that quality of life a little bit more over the other 4 subscales. And that's basically the premise of this paper. We classified individuals in 2 different manners. We classified them based on their quadriceps strength and based on this clinical knee-related symptom state.
I think I'm a little bit more familiar with the Luton criteria, and I know that criteria also had like a clinical examination and some imaging attached to it. Is it very similar as it relates to the England criteria to help us understand the symptom state?
Yeah, so there is some similarities between them. I know that Dr. Matthew Harkey came out with a paper kind of looking at those 2 very recently. And so we chose the England criteria over the Luton just because it uses the KOOS, which is more commonly used in this return to sport assessment to kind of track progression throughout ACL reconstruction. And that's kind of where we decided it would be more clinically applicable to look at how these individuals are doing. And it's a lot easier to assess in the clinic rather than, like you said, the Luton criteria has all these other kind of more complex metrics to look at. And so we were just kind of looking for something that's more clinically applicable that clinicians can use, maybe with something they're already using for return to sport. And that's kind of where we came from. Chris, anything to add?
Yeah, I think the other part was we were sort of looking at why the criteria were established, and the Luton criteria were really established as a kind of identification of early stages of osteoarthritis, which is very important in patients with ACL reconstruction. So like up to 1/3 of patients will have early osteoarthritis within 10 years of ACL reconstruction, and 50% within 20 years, which like for a 16-year-old is when they're 36, right? They probably have little kids running around at home, or they're just getting to kind of peak in their career at that point, and they've got arthritis, which is a scary thought. But what we were really interested in was more just sort of a general symptom state. Like, does your knee bother you or doesn't bother you? Do you have pain? Do you feel limited in doing things? And that's really what the England criteria was developed for. Now, we could have a long conversation about how these criteria were validated, how they've been applied to things, which populations they seem to be more effective in or less effective in. But we thought like straightforward, simple, easy to understand, single questionnaire, just get to the point. We're not trying to make this any more complicated than it needs to. And I think that often can be a really helpful approach. While my mic is turned on, Shelby, one thing that you mentioned earlier was just around this kind of variability in assessing strength and like when do you do it and how do you do it. And I think the big take home, and I think Michelle would agree with me on this point, is like, just measure something. Like there are lots of ways to go about this. And for a long time in my clinical education and education for others, the manual muscle test was like the standard practice for strength assessment. And I think as a field, we've evolved beyond that in many ways. We sort of understand the limitations in a manual muscle test or why that might not be the most appropriate approach. But when it comes to strength assessment, if we're thinking about the physiology of the contraction, are there differences between an isometric and an isokinetic contraction? Of course there are. But using a tool that gives you a number that you can track over time in a reliable way is really sort of the most important thing. And so if that's a handheld dynamometer or an adapted handheld dynamometer like Terry Grindstaff or others have kind of shown how to stabilize it on a table, or whether it's using like a really inexpensive push-pull strain gauge that costs $100, like John Gutchis at James Madison has published some papers on how to adapt really inexpensive scales and tools to do strength assessment. Whatever it is, get a number so that you can track that number over time. Because with a manual muscle test, it's how strong you're feeling on a given day and how strong your patient's feeling on a given day, and whether you had your Wheaties and your coffee or not, influence how you perceive that test. Whereas it's really hard to trick a dynamometer, and so that's kind of why we push in that direction. I know it's more challenging and more complicated, kind of the opposite of what we just said about our CUS criteria, but getting a number is a really powerful thing.
Yeah, I think one more point to add is test multiple times. So having one metric or one instance is not going to be indicative of kind of what that patient's actually doing, because they might not understand what you're asking them to do in the clinic, or maybe they're fearful of something. So just, I would say on top of that, objectively measure, but also measure multiple times in one instance.
So if you're listening to this podcast right now, go ahead and dive into some of these resources and figure out how to objectively measure quad strength in your clinical practice. So I totally agree with both of what Chris and Michelle have said too. So really good take-home point identified there. So bringing it back to your article just a bit, what all did you find as it relates to isometric quad strength and quad strength symmetry as it is associated with clinical knee-related symptoms?
So like I said earlier, I kind of mentioned this, but kind of blew past it. We classified individuals in two different ways. So we classified them based on their England criteria. So did they have unacceptable clinical knee-related symptoms? So they were below those metrics I had mentioned earlier. And then we also classified them based on their quadriceps strength and their ACLR limb, as well as their limb symmetry index. So we parceled out these individuals, and we had 4 groups that we ended up with. We had individuals who met both the strong and symmetrical piece. So they were above 3 times their body weight in that ACLR limb, and they were above that 90% symmetry. We had a strong only group. So they only met that strength criteria and they were below 90% for their symmetry. We had symmetry only. So they were above 90% symmetry, but didn't meet that individual ACLR limb metric. And then we had the neither strong nor symmetrical group. So they didn't meet either of these criteria. And these individuals were between 5 and 7 months post-ACLR. So they've been through their rehabilitation. They're kind of in this latter stage of rehabilitation, transitioning into more sport-specific and like higher level function at this point. So I just want to keep that in mind for anyone that's listening. I think the most interesting thing we found was that of the 173 participants that we included across these 3 sites that we worked with, and thank you to all of our collaborators on this project, because we wouldn't have been able to do this without you. We found that 65% of these individuals were in that neither symmetrical or strong category, which is crazy to think about as a clinician. Because a lot of times, there was an article recently published by Burroughs et al., and they were saying how most rehab or physical therapy visits are used up by 16 weeks post-op. So they've transitioned out of rehab, and now they're not even meeting these common clinical thresholds that we have objectively. So that's a little bit concerning. If you want to be more concerned, 85% of our entire sample did not meet one or both of those quadriceps strength metrics. So that is kind of an eye-opening piece to kind of think about. And we've kind of seen this in our data sets as we've been writing more papers recently. So it is definitely something we need to think about, I think, as clinicians, of how do we improve our care for these individuals, because we want to see them ultimately go back to sport or back to their physical activity or back to their activities of daily living without having this fear of re-injury or any complications afterwards. So we did unfortunately find there was no association between saying that I have acceptable clinical knee-related symptoms and I meet the strong and symmetrical criteria. So there was no association there from the data. And it also didn't hold for anyone that was in that symmetrical only group to be acceptable clinically for that knee-related symptom. And I think kind of this came from our groups were incredibly unbalanced. As I said earlier, based on how individuals met these strength criteria, we had 65% in that neither strong nor symmetrical, and only 26 individuals that were in our strong and symmetrical group. Our strong only group only had 4 individuals that met it. And then our symmetrical only group only had 30 individuals. So I think this kind of unbalanced grouping was kind of the main player in what we found. However, I think it is important to know that this is, I think, pretty representative of the clinical population that we see. So kind of caveats there to think about. Chris, anything to add?
I think that it's interesting. I'll take it from the flip side instead of on the quad side, the symptom side. If we look at patients who are between 5 and 9 months after ACL reconstruction, somewhere between 30 and 45% of those patients are going to report unacceptable symptoms that are limiting their ability to be active. And that doesn't take into account other patient-reported outcomes that also have a negative impact on their ability to be active, things that are more in Shelby's area of expertise, right? Things around confidence and grit and anxiety and social support and all these other factors that are super important. Not that those don't influence symptoms as well, but there's lots of people that have independent processes outside of symptoms related to those things. And so, I do think we sort of do this thing when we have these interviews where we're just talking about the bad stuff, right? Like, oh my God, so many people weren't symmetrical and so many people have symptoms. And it's true. I think clinically, if you were to objectively evaluate or to get an outside evaluator to come in and test all your patients, you're going to find that a lot of them are probably not where you'd like them to be from a metrics perspective. What's interesting, or what I think is good, is that a lot of these patients are still pretty active after they've had surgery, and they have a pretty long active lifespan, and things in general seem to be pretty okay. I mean, it's a life-changing procedure that does a lot of trauma to the joint, and for the majority of patients, if you ask them at 1 year or 2 years after surgery, they would indicate that they were satisfied with the procedure and that they would do it again if they had the opportunity to in order to address their concerns. So, again, not saying symptoms don't matter and that quad strength isn't important and that we shouldn't try to mitigate symptoms or reduce re-injury risk, but we do also want to, every once in a while, take a look at the good side of the coin and say a lot of patients are pretty happy with the way things went, and something seems to be going okay with their current care. We can definitely improve, but that's kind of where we are right now.
So it sounds like definitely some areas for improvement, but also making sure we take the time to acknowledge that we're doing a good job and we just want to continue to provide the best care that we can for our patients moving forward. So based off of what you all have found in this article and about some of the conversations we've had today, what are the next steps? What's the next step to future research or clinical practice? What would you recommend for a clinician to do based off of what you found in your paper?
Yeah. So although our hypothesis didn't hold true, I think it's important for clinicians to consider that subjective and objective assessment throughout this process. And so whatever your clinic uses as those metrics, and whenever you start testing, just make sure that you're not only getting that objective feedback. Obviously, we know from a physical therapy standpoint, billing, that's super important. However, we interact with our patients, athletic trainers, physical therapists, anyone who's in strength and conditioning. We see these individuals multiple times a week for several minutes a day. And so we want to make sure that we're hearing what they're saying, what their goals are. We want to be as specific as possible. So we also want to track that subjective, like how are you feeling today and how are you feeling the next day, and kind of along this progression, so that we can continue to provide this quality care for them and this patient-specific care. They want to get back to activities that are salient to them. So we want to make those activities salient to us as well as clinicians. So like having this ability to combine the subjective and objective, I think, is the way that is most appropriate to address our patients, instead of just treating them as a number, treating them as an actual individual with their goals in mind. I think some of the things that have come out of this project, as well as some of the other projects we've worked on in our lab, is just kind of this understanding of what is normal. Like, what is normal in healthy individuals? As researchers, the best thing would be to track everybody. And then if they get injured, we know pre-injury what they were looking like. realistically, we know that's not really possible. So how can we understand from a healthy perspective what is normal for symmetry metrics, for hopping, for strength? I think we've done a better job psychologically understanding maybe what healthy looks like comparing these individuals. But functionally, I think we kind of forget that piece a lot of the time because we're so concerned about these individuals after this traumatic surgery and injury. But I think now we're getting to the point of like, what is normal? So what can we compare these individuals to? So I think looking at that is super important moving forward. And then as a clinician, for any young clinicians or even seasoned clinicians out there, just try to look into the evidence. What is most recent? What's going on? I think we get stuck in these ruts of just, I see something, I hear something from my colleagues, I read it, and then I hold on to it for several years until I hear something different or I see something different. So just try to check in with the literature or your colleagues every so often, whether that's having, maybe clinic-wide discussions or just informal discussions while you're at the clinic. And for any young clinicians out there, don't be afraid to ask questions of those seasoned clinicians. They're going to be kind of your best resource for where to go, who to ask, conferences that you can attend and network, those types of things. So I think ultimately we all have this goal of getting our patients back to return to sport or return to physical activity or return to daily living with the highest quality of care in mind. And I know as a clinician, one of the things I struggled with is just time. You don't have enough time in the day with each patient one-on-one to kind of get at them, but how can we educate them beyond the clinic to send them home with home exercises and things that they can really hold on to and kind of take with them as they progress back on their own?
And I think
Michelle, one of the things you were... Go ahead, Chris.
Sorry, I was just going to say, I think from my perspective, we already sort of covered a lot of the points, like measure things. It's important. I know numbers are hard to manage sometimes, and where do I put, how do I store it during the assessment so that later on I can put it in the EMR, and I totally get all those limitations that happen on a daily basis. We collect the majority of our data in the clinic here at UVA, and so like we get it. It is really challenging. What I would say is that there are a lot of online tools now that make your life a lot easier. So the CUS is available in a fully interactive online form. You can have it open on a browser on your computer or tablet. Same thing with the IKDC and the ACLRSI and a bunch of these other scales. Or there's downloadable spreadsheets where the patient can just click right in the spreadsheet what their answers are, and it will tabulate the scores for you. And so Google is a powerful tool, or Bing, or whatever you use. And there's a lot of useful tools that are out there that will help in cutting down some of that administrative burden in a way that can help you to do this stuff. And then the third one would be, I think, kind of trusting your eyes in what's in front of you. If you think a patient's in distress, they probably are, and using some good kind of not leading questions, some open-ended questions that allow the patient to sort of lead you in the direction of what's going on without interrupting them or without trying to push the conversation in a specific direction that you're interested in. Even just for a minute or two goes a long way in getting understanding of what's actually going on with the patient. So measuring the CUS is awesome, but you can also just ask the right questions and get someone to tell you that their knee's been bothering you, or that they've had some symptoms or something that's popped up, or they mowed the lawn this weekend and their knee hurts as a result, right? This is all stuff that you can get through a good clinical interview.
Yeah, I think on that.
Not being afraid to refer out if you need it as a clinician. Sometimes it's beyond our scope of practice what these conversations lead to. So just like Chris said, have those open conversations with your patients and use your eyes and your ears to really make and help your clinical decision making. I just really love this underlying biopsychosocial approach to patient management that has occurred in our conversation, because that's really what I love discussing. So I really appreciate the conversation and the take-home points you provided for our listeners today. Any other last-minute take-home points or conversation points? Anything you want to discuss from like measuring any of the quad strength, the PROs, maybe like an online dashboard or something that Dr. Kuenze has created that may be helpful?
Yeah, so this will be my last plug. Of course, it's at 30 minutes into the podcast, but it's fine. Yeah, we created an online tool that's meant to help clinicians generate like report cards for their patients based on their functional and patient-reported outcome measures. Right now at acldashboard.com, we have an interactive tool that'll let you do that for adolescent patients who are in that 5 to 7 month period after ACL reconstruction. It's based on data from about 800 patients. In the coming month, we should have updates pushed for that tool that should include adults at the same time point, as well as adolescents and adults at earlier and later time points. So currently we've got about 2,000 patients worth of data, and we're pushing about 4,000 patient encounters that'll power that tool. And so it gives some fun graphs and it compares it to the large data set. When you input someone's hop distance, it tells you that they fall in the 87th percentile or 55th percentile. I think of it like a height weight chart for ACL reconstruction. So hopefully that's something that can be helpful. It's also printable. So after you generate a report, you can hit Control P or Command P, whatever your print command is, and actually print a PDF of it and upload it into the EMR so that you've got kind of longitudinal data on the patient that's in front of you.
And then give that link one more time for our listeners.
Sure, it's acldashboard.com. We tried to make it pretty simple. I can also put it in the show notes since I'm the one who's going to be editing this video. But I'm happy to make sure it's there as well so that clinicians who are interested can access it.
Awesome. Well, Chris and Michelle, thank you so much for joining me today. And this article will be available free of charge by the Journal of Athletic Training. And I highly recommend everyone go and download this manuscript in a future issue of the Journal of Athletic Training. Again, thank you so much, and we will see you next time.